Next slide. Again, thank you so much for joining us today for our webinar called Fostering a Healthcare Workforce for Today's Social Challenges. As you know, this is a part 2 of a 4-part national webinar series brought to you by the Social Determinants of Health Academy. Next slide. Before we get started, I just want to provide some housekeeping notes. So all participants are muted upon entry to limit background noise. Use the QA or chat box to ask questions during the session. We will provide time at the very end of today's session to go through and answer some of those questions. This webinar is being recorded and materials will be emailed to participants. And finally, we'd love to hear your feedback. So at the end of the session, please take a moment to fill out our brief evaluation so we can improve future sessions. Next slide. And for those of you who are new to the SDOH Academy, we are a HRSA-funded virtual training series designed to help staff from health centers, health center controlled networks, and primary care associations develop, implement, and sustain SDOH interventions in their clinics and communities. The power of the SDOH Academy is that it does not function on a single intervention. Instead, multiple HRSA-funded national training and technical assistance partners work together to offer a coordinated curriculum on multiple community-based SDOH interventions. If you'd like to learn more, please feel free to visit us at sdohacademy.com, and I'm going to go ahead and link that here in the chat. Next slide. So you may have heard the National Training and Technical Assistance Partner phrase before. We are NTAPs, and NTAPs, for those of you who are unfamiliar, maximize the impact of health center programs. We do this by increasing access to high quality, comprehensive healthcare for underserved populations. We support HRSA awareness of issues impacting health centers and special populations. And we support health centers to identify and implement evidence-based and promising practices and leverage health centers' shared experience and data to improve health outcomes for patients. So if you want to learn a little bit more about NTAPs, please visit us here on this website. I just also posted that in the chat. We're here to help you. So please take a moment to get to know us a little more. Next slide. And these are the 19 NTAPs that make up the SDOH Academy. Next slide. I'd like to take time to acknowledge everyone that participated in making today's webinar possible. So thank you to Shamika Davis, our program manager at School-Based Health Alliance, and Helen Reha Vernier, a senior training specialist at the Association of Clinicians for the Underserved, both of whom were instrumental in developing today's content. My name is Shannon Patrick. I'm a health strategy specialist at MHP Salud, and I'll be joined by Kavanya Elcia in a moment, and she is a Director of Justice, Diversity, Equity, and Inclusion at Healthcare for the Homeless Council. And I'd like to take a moment to acknowledge the reason why we're having this conversation today is a result of the legacy of theft, genocide, and slavery that started with the colonization of this land. The indigenous people of Turtle Island, aka colonized America, teach that soul wounds are the cumulative historical trauma that has been passed down through generations. America's soul wounds encompass the historical and current injustices that skew our perceptions of ourselves and those with whom we share this land, and show up in every clinic or patient room across America. Every story of being judged, dismissed, or blamed for one's medical and social condition stems from these wounds. And although we are clearly not the creator of these wounds, we do own them through inheritance. And I'd like to just take a moment to acknowledge the team that put this webinar together reside on the ancestral lands of the following. So bear with me, I'm going to do my best to pronounce these names. Denver, Colorado, which resides on the land of the Arapaho, Cheyenne, Nu'uagu, Tuvupu, Ute, and Ochein Chacoven people. Dearborn, Michigan, which resides on the lands of the Peoria tribe and the 39 tribes of the Anishinaabe Abawaki Nation, Miami Nation, Meskwaki Nation, Wyandot of Anderson Nation, and the Potawatomi people. Collinsville, Illinois, which lies on the Osage Nation, Quapaw Nation, Ocheki Chacoven Sioux Nation, Kikapoe tribe and the Kaskaskia Peoria and the Miami tribe. Orlando, Florida, which lies on the ancestral lands of the Seminole tribe, Miccosukee tribe, and the Muskogee tribe. And then lastly, in Tacoma, Washington, which lies on the ancestral lands of the Puyallup tribe and the Confederated Tribes of Umatilla Indian Reservation. Next slide. So by the end of today's webinar, you will be able to understand how the healthcare workforce addresses the SDOH, understand how the various supports and resources available to the workforce, and learn tools and strategies to identify current and emerging SDOH needs to continue to support the healthcare workforce as their communities change. So first, how does the healthcare workforce address the social determinants of health? Next slide. So the social determinants of health, you may also have heard the term social drivers of health, are the conditions in the environments where people are born, live, learn, work, play, worship, and age. These all affect a wide range of things, including health, functioning, quality of life outcomes, and risks. So you can see here in the image provided that the social determinants of health make up 5 main domains. Those are education and access to quality, economic stability, social and community context, neighborhood and built environment. And we heard about this in the part 1 of this 4-part webinar series. So if you weren't here, I highly encourage you to go back to the SDOH Academy website and check that out. And then lastly, healthcare access and quality. FQHCs are meant to provide access to quality healthcare, and they're often the access point for many to access to connect to health and social services, which is why it's so important for this workforce to be able to effectively screen for the social determinants of health, identify needs of their patients, and then follow through and address those needs. And we definitely need to continue to look at this as our communities evolve and change. Next slide. So in order to adequately address the social determinants of health, we need a workforce that is equipped to understand the challenges the community faces, and also there also needs to be someone that patients trust to help them and share those challenges with them. So community health workers, or you may have also heard the term promotor or promotora de salud in Spanish, they're often the first profession that comes to mind when we're thinking about collecting SDOH data and addressing those needs. So a community health worker is a trusted member of the community who empowers their peers through education and connections to health and social resources. They have proven to be successful at increasing health outcomes for their communities because of their deep understanding of the cultural norms of the people they serve, as they're often members of the community themselves. They educate their peers about disease and injury prevention, work to make health services more accessible, and strengthen their communities to create positive change. So CHWs often look like the communities they serve, speak the language, and they're therefore key to building trusting relationships with communities. And there are many legitimate reasons why vulnerable and underserved populations don't necessarily trust our medical system. And so CHWs can really be key to rebuilding or reestablishing trust, or building trust if we're a new organization with our communities. Next slide. So again, CHWs are a critical workforce for addressing SDOH needs. They bridge the community to health and social services. They build trust. And there are many roles and core competencies that can support them in addressing those needs, right? So we have cultural mediation, culturally appropriate health education, case management, social support, advocacy, capacity building, direct services, assessments, outreach, evaluation, and research. There's a plethora of things that CHWs do to work directly with the community and address those social determinants. If you'd like to learn more about these roles and core competencies, I highly encourage you to check out the Community Health Worker Core Consensus Project, or the C3 project, by visiting c3project.org. There you can find a lot more information about these core competencies and the scope of CHW work to address the social determinants of health. Next slide. You may have also heard of enabling services are very key and important with addressing the social determinants of health, and this is true. CHWs sort of fall under this enabling services umbrella, but other enabling services providers could include case managers, translators, interpreters, transportation, health education, enrollment assistance, and more. As you can see here in this slide, these are some of the different types of enabling services staff that we see at FQHCs. Health centers who use enabling services have a higher likelihood of getting enrolled in health insurance coverage, getting a routine checkup, getting a flu shot, being satisfied with care overall, and also, getting their needs met when we are asking the right questions. So next slide. If you want to engage with this slide, we want you to go ahead and join us at menti.com and use the code above on this screen. But who at your organization is collecting SDOH data? It's not only community health workers, promotores, enabling services. Who else might be collecting SDOH data? Feel free to type in your responses. Front desk staff, check-in, county. Yes, specialists for SDOH collection, doctors, MAs, navigators, counselors, nursing staffs, program managers. This is all great. Yes, everybody. That's great. In the chat, we have MDs, MAs, all team members. Wonderful. Let's go to the next question and see. So besides the people trained to collect SDOH, who else might hear about SDOH needs and respond to them? This may or may not be similar to the previous question, but feel free to think about that. Providers, social workers, everyone in the clinic, exactly, yes. Schools, so we definitely think about other settings beyond the clinical care setting where schools, food pantries, partners potentially, other patients. Great, thank you so much. Next slide. So you guys kind of hit the nail on the head there. Anyone who comes into contact with patients at a health center or potentially a trusted partner organization is able to collect information on the social determinants of health for that person. One thing that's also helpful in building trust with the community is just ensuring that staff are reflective of the community they serve. So that people feel comfortable and feel as though they're welcome at the place they're coming to receive care. And they're also more likely to share their needs at that time. Kavonia, did you want to say something? Okay, I thought I saw you come off mute. Great. Yes, next slide. So right in hand with that, building trust with the community is key to addressing the social determinants of health. If we don't have trust, people are not going to open up and share their needs, and may even be fearful of doing so. We want to ask the right questions. We want to be able to foster that trusting relationship so that when we do ask those questions, people are giving honest answers and able to open up. The next step is to definitely document what we're hearing, right? So a lot of times we have these tools that we use to collect the social determinants of health, and it might be something that's done when someone arrives at a clinic or one particular individual is tasked with asking those questions. But it's important to note that at various points throughout a visit or encounter with a patient, they may be bringing up needs that were not caught in that screening tool. So being able to document those needs and report those to communicate them to the healthcare team is really critical. And then, of course, you're able to develop a plan to address those needs. But without this trust piece at the beginning, we're not able to even identify any of the needs that people might have to begin with. So one strategy to share, yes, go ahead. Does your organization use team huddles? Please join us in the Menti, menti.com, use that code above and let us know. Are you using huddles? If you don't know what a huddle is, there's no shame in that. We'll definitely talk about it. So feel free to let us know. This is great. So it looks like a lot of you are using huddles. This is wonderful. I will say in my conversations with health centers, not everyone is doing it or not doing it regularly, and some might not necessarily know how beneficial it can be. Great.
And we didn't ask this, but I'm super curious to know who is not included in the team huddles, right?
Yeah. So when we think about the team huddle, is there anybody that's missing from the team huddle that you think could be beneficial that maybe you'd want to bring up with your healthcare team? Feel free to answer in the chat. Okay, front office staff, IT. Yes, there are folks. Back office. Okay, everyone's included, but you have a small staff. Okay, different huddles for different regions. Okay, specific with CHWs. Great. This is great. All of our team members are welcome to join huddle, but it is very difficult to find a time when everyone is available simultaneously. Yes, definitely a challenge to get everyone in the same space. Great. Awesome. So I think I'll answer some of the questions here in our next slide, and then we'll definitely be able to answer more questions towards the end of the webinar. So a team huddle is important. And, it's really nice to see that all of you, for the most part, engage in a team huddle or know what's going on. And for those of you who aren't sure what it is or aren't engaging, hopefully this will be a little bit more information to bring back to your team. So in order for a patient to be seen, we know there are many steps that must take place, many individuals involved working together to ensure that that patient visit goes well. A huddle is a short stand-up meeting lasting 10 minutes or less, so just kind of in a nice convenient place in the office. These meetings are typically used at the start of each workday in a clinical setting, and the main purpose is to discuss the patient process to be formed during that day and actively manage the quality, safety, and effectiveness of the services provided. So routine huddle meetings contribute to an interdependent team culture, improved relationships, and the delivery of a safe and reliable patient care. And similar to the question that was just asked, the huddle meetings should involve all team members that can offer valuable input to a clinic flow and patient needs, which is the key here, such as providers, medical assistants, nurses, social workers, case managers, and even community health workers. CHWs offer expertise in the dynamics and culture of their patients, and they can provide invaluable insight to health behaviors, and they can share the SDOH needs and concerns that a patient may have that have been brought up maybe in a different setting outside of that SDOH collection tool. All of this can help clinicians determine the best possible treatment for a patient. So it is important to have this interdisciplinary team and having all members participate in huddles. And one thing that's important to note is a huddle should be a space where everyone has a seat at the table and each member's skills, knowledge, are valued. So, and considered, right? So making sure that everybody feels safe and sharing something about a patient that they're working with and that they're listened to so that the team can provide better support to that patient. And so everyone's working together and coming together to address those patient needs. Yeah, we just definitely want to make sure that we're including everyone and that everybody feels safe and comfortable speaking. All right, thank you so much. So for those of you who do not currently include community health workers or potentially other enabling services staff or individuals in your team huddles, and you're wanting to learn more about integrating those folks into the healthcare team, definitely check out this resource. I'm going to go ahead and post the link in the chat here in a moment. But we have a resource on our website at MHP Salud that really talks through the different components to consider when integrating community health workers into a clinical care team. That's integration with the EHR, team huddles, telehealth, and clinical decision-making. There are case studies involved where other FQHCs have shared their experience in doing these, and there's some lessons learned. And so I think it could be a really valuable tool for folks who are trying to address this social determinants of health through integration of other key personnel into their healthcare team. And with that said, I'd like to pass it on to my colleague Kavonia to share more about building a culture to support SDOH needs.
Thank you, Shannon. And I see that there's 2 people who have their hand raised. If there's something you need, please put it in the Q&A or put it in the chat. And Shamika, who's working behind the scenes, can help answer whatever questions or get a message to us so that we can answer whatever questions you have that you're raising your hand for. So there are many factors that contribute to SDOH needs that patients and staff have to navigate daily. And it's really super important that we take a both and approach when looking to address SDOH needs. We need to see the acute individual need that's in front of us, and we also need to acknowledge the bigger systems at play that contribute to these individual needs. And so while we're tending to those individual needs, we also need to make sure that we are leveraging community partnerships to help address systems in place that contribute to the needs that we see our patients needing to navigate. And so we're going to be talking about that more, but that's the whole message of this image. I want you to see that the individual factors and individual behaviors are just a small piece of it. There is a greater system at play that also has a significant impact on the SDOH needs that we face on a regular basis. Next slide. So for now, we're going to focus on the individual level for staff and patients in order to address SDOH needs in a meaningful way. There needs to be some foundational supports in place for both staff and patients. So for staff to be able to be well-resourced and equipped to handle the SDOH needs that come in from the communities that we serve, staff need psychological safety and the benefit of interdisciplinary teams. So like Shannon said, when we do those huddles, everybody needs to be there because that front desk person has a superpower. That front desk person has input and wisdom to offer. Your community health worker has wisdom to offer, the MA, the nurse, right, as well as the provider, because each of those are touch points around throughout the patient's experience and journey within that appointment. And each of them are going to be able to connect with patients in different ways, particularly in different and meaningful ways, and get different information from the patient that really has an impact on the full picture of how we can provide equitable and meaningful care. Staff also need to adopt an equity mindset. I would say the organization as a whole needs to adopt an equity mindset. We also need to be able to navigate our affinity bias as a care team and leverage patients' affinity mindsets, which we're going to talk more about. Our staff needs training, both clinical and administrative staff, because as you pointed out, everyone who touches patients, when we were asking who collects SDOH data, y'all listed everybody. I was doing a little happy dance in my seat because even someone in finance, right, who is following up on a bill or someone in the insurance who's following up on a claim, right, is going to contact that patient, and they may find out that part of the problem is that part of the problem of why the bill isn't paid or the complication exists is because there's an SDOH need. And so admin and clinical staff need to be trained, as well as there needs to just be internal support structures and practices for staff. When we're focusing and shift our gaze more externally for patients, we need to cultivate psychological safety for them. Shannon mentioned it, and we're going to take a little bit of a deeper dive into it in a little bit around medical mistrust. We need to let patients know that we are a safe space. We need to understand the 70-30 rule and the need to leverage partnerships, because again, what we do in the clinic is and personal choice is only a small bit of that rainbow that I showed you. There's a lot of other things that have impact and influence that may be outside our wheelhouse, and with a community partnership, we can still have some impact and effect because again, we're trying to help build this whole patient's well-being. And I'm going to discuss what the 70-30 rule is. Navigating medical mistrust and other systems of mistrust, addressing health literacy and readiness, as well as support structure for patients and partnerships. So we're going to go over that. Next slide. So Psychological safety in our interdisciplinary teams. Psychological safety means that I, as a learner, which we all are, no one knows everything and perfection does not exist. As a learner, I can ask questions, I can admit mistakes and knowledge gaps. As a contributor on my team, I can offer my perspective and ideas freely without regardless of hierarchy. So this means whether I'm a front desk staff or a provider, right? Like I am respected and seen and valued the same way. And my ideas are valued the same way. As a challenger, I can raise concerns or conflicts without fear of reprisal or reprimand. And as a member of the team, I feel seen, heard, and valued. I want to point out that psychological safety doesn't just happen. We actually must sit down with one another and create this container because we all have different styles and needs when it comes to communication. Psychological safety requires us to embrace our discomfort, own our intentions and our impact, disagree with civility, and separate ideas from people, meaning that I'm not saying that you're a bad person just because if I bring something up as a challenger, I'm not saying you're a bad person. I am not personally attacking you. I'm saying I'm struggling with your method of engagement or your recommendation. We also need to identify and agree upon what it means to be respectful. And this is not about hierarchy. It's about seeing each other's shared humanity regardless of hierarchy and agreeing to be called in when we default into harmful norms. I would also say that a baseline of trust is needed, and if harm is experienced, that we need to engage in restorative practices. And so again, this applies. So I was talking specifically about internal dynamics as we get together as a team, because no one person can meet all the needs of the patients that we care for. So this is not just the social worker. This is not just the community health worker, right? This is all of us together. But patients also need the same level of psychological safety. So everything that I just mentioned for internal staff also applies to patients. Psychological safety for patients can look like, I don't have to pretend to be heterosexual while having my reproductive needs addressed. If someone is navigating substance use disorder as a way to cope with my trauma, I won't have to lie in order to be accepted in a program or to receive unbiased medical care, right? That's what psychological safety looks there. I saw a couple of questions popped up, and I'm going to, again, talk more about the 70-30 rule. Is there anything else? Okay. And Shannon, you're still spotlighted. I mean, I don't mind not being in the spotlight. I actually prefer not to be, but just wanted to point that out. Next slide. Oh, okay. Next, again, and the slides are all broken up. On the left, it's all about staff, and on the right, it's looking at externally at the patients. And again, if you have a question, just put it, instead of raising your hand, just put it in the chat or Q&A. So what do I mean when I'm talking about navigating affinity bias? So bias can work as a benefit or a harm to a patient. Affinity bias is either fed by stereotypes or social narratives of anyone who falls outside what we deem as our inner group. And when this affinity, so like my inner group would be, oh, other Black women or other Black queer women, right? Or other nurses, right? The people who I have things in common with. When affinity bias is in play that's fed by stereotypes, it has consistently fostered inequities. Affinity bias that's fed by mutual shared identities or ideals, on the other hand, can also be problematic because it gives preferential treatment and grace to those who we hold an affinity for. So a perfect example of this is my colleague Kate works in a medication-assisted treatment program for people who have substance use disorder. And they found that the providers had an affinity bias to white males because the white males were receiving additional medication when compared to the rest of the program participants. And And it's because they went back and looked at their data. And when it was questioned, every provider, because it was different one, it wasn't the same one, it was different ones across the program. Every time it was like, oh, this was a special circumstance. Oh, this was a special circumstance. And because they were engaging from an equity mindset, the question was, what none of the other non-white, non-male participants ever had special circumstances that required supplemental medication? That's very highly doubtful. It was the affinity bias, right, that was feeding the actions of these providers, excuse me. And these affinity bias will show up in what policies and practices we support consistently, and who we support and enforce them with, right? Because this program had a policy and procedure around prescribing an additional medication, and it wasn't strictly adhered to for this white male population, because again, they were allowed grace and given additional medication because of special circumstances, where others who did not identify with that group, right, didn't receive those. And so patients can demonstrate affinity bias as well. And again, if it's based in stereotypes or societal narratives of anyone who I deem as like doesn't fall outside the hierarchy of whiteness. So this is the white Anglo-Saxon, middle-aged, able-bodied, heterosexual, able-bodied, educated male person. Anybody who falls outside of that category will be seen as other. And so these patients who have affinity bias based on those stereotypes, they are the ones that ask my colleagues and are told when they come in, I want a white doctor if the doctor in front of them isn't white. Or they'll ask and say that I want a doctor that speaks English if my doctor happens to have an accent. Or they'll ask if the doctor is old enough to practice medicine. All three of these scenarios have happened to multiple providers that I have been with multiple times by multiple people. And this is an affinity bias that's, again, projected from the patient to the provider, but it's rooted, again, in bias and stereotypes and is harmful to the provider. But patients can also engage in affinity bias that's fed by mutual shared identities. And this is something we want to leverage so that it can help both the patient and the care team. Because if we can cultivate, because of that affinity bias based on like, oh, okay, we're the same, if we can cultivate street cred or trust, which is basically, I trust you enough to help me with, and literally fill in the blank, or it allows for grace to be given if a patient has a negative experience, because again, our street cred in the community is that we are known to provide quality care. So then again, I have more grace, I'm willing to forgive, I'm sure this was just a one-off, right? Rather than you are purposely doing X, Y, and Z to me. And so that's a way that we can positively leverage that affinity bias. And that is where our front desk staff come in. That's where our community health workers come in. Sometimes it's your MAs and maybe even your nurses. I know that when I was doing, my background is as a registered nurse, been doing it for 19 years. And when I was doing street outreach and I was located in permanent supportive housing, that association affinity bias, being like, oh, this is a Black nurse, I can trust her, helped me out immensely in helping my patients meet their health goals. Because although they didn't necessarily trust the medical system, they trusted me. So I wanted to share a story. So again, as a street outreach nurse, I had a patient who we're going to call Ty, was not his real name, and he had a woman of color provider, and she did everything she was supposed to do that she learned in cultural competency class, right? She tried to get his buy-in, she asked his opinion, and Ty would yes ma'am her to death. Yes ma'am, yes ma'am, yes ma'am. But the one thing she never did, which is what we're going to be talking about next, is she never acknowledged that she had a 70-plus-year-old Black male elder in front of her who has a lived experience of being unhoused, substance use disorder, was disabled and wheelchair bound. And by missing that, she missed really, right, developing that trust or that street cred connection with him. And so when he would leave her office, because we always went together, he would turn to me and he would go, I'm not doing any of that. And then I would take a breath and I go, Ty, why not? What is it? What was it that you didn't agree with? What didn't you like? What are your concerns? And after him and I talked it out, I would legitimately get him to agree to do and follow up, and together we would do it 90% of what she recommended. And the difference is me and him, I, as an outreach nurse, I had the time to develop and cultivate that relationship with him. So I knew that as a 70-plus-year-old Black man, I'm like, he was around when Tuskegee happened. His grandma picked cotton for a living, right? So he has had some really traumatic and trauma around social services and the medical system. And because of that, he had that distrust. And so by talking this out, by A, first of all, acknowledging it, and B, talking it out with him, right? I was able to make that connection, build that resource, and gain that trust for him so that he, although still he has transitioned on to his dying day, did not trust the medical system. He trusted me to protect him. And that's a superpower our front desk can have. That's definitely a superpower our community health workers have. And again, sometimes our RNs and MAs. Are there questions that I need to pause for? Or do you want me to do it at the end?
I'm doing my best to answer some questions as we go, and then we can add the ones that we don't finish, we can get to them at the end.
Awesome. Okay. All right. So again, community health workers, MAs, are frequently underused sources of support, information, and collaboration on our medical teams. And as you just heard, like, again, they have this superpower because they are our best kept secret, because they can provide this insight that a provider may not know. When we went for his appointment, the front desk staff communicated with him and connected with him in a way, right, that provider didn't. So keeping these people and these roles within our interdisciplinary huddles are super important, because it allows for genuine collaboration and helps share that load, because our patients have complex histories and complex needs. And it really does take all of us. Switching over to the patient side, I would definitely say at least 50% of our patients hold at least one marginalized identity within current societal norms, which means that the systems that are in place have been designated them as other, and thus they have experienced trauma, whether personal or collective, as a result of navigating the various systems that it takes to live our daily lives. And if you think back to that rainbow, there's a whole bunch of systems that we all have to navigate, right, to go about our daily lives. And depending on how many marginalized identities a person holds, the likelihood of trauma experience increases. So this means that when they come to see us, they are likely already expecting to experience problems. So it's important that we decide how we are showing up for patients and how we are showing to them, demonstrating to them that we are a safe space, and yet not another system that is going to add to their burdens, rather than supporting them and cultivating their definition of health and well-being. I have another story where a patient of color came in, and one of my BIPOC providers was providing care, and he had come in previously and seen another provider that he was not familiar with, and explained all his issues. They treated whatever. He was coming back for a follow-up, seeing my provider. And she was super concerned because based on what he said, she was just like, if you're still having this, then we need you to go to the emergency room. This is beyond what we can treat here in the clinic. We need you to go to the ER. And the patient had to admit that when he saw the first provider, and my doc didn't find this out until 40 minutes into her follow-up appointment, which, you know, if you do any scheduling, a follow-up appointment ain't never 40 minutes long. It's more like 15 to 20. But he had to admit that he exaggerated his symptoms with the first provider because he didn't know if he was going to be believed or not. Right. So again, if we lay that space, if we do that foundational work of letting people know that, hey, this is that we are a safe space and this is how we are a safe space, it really can help, right? Give the patients that reassurance that this team truly sees me as I am and accepts me and cares about my health and well-being. And it helps our providers because then they can actually get to the root of what the real problem is. And what this patient did is not an isolated incident, particularly for marginalized people. Our collective experience, regardless of education, age, class, SOGI, or ability, is that the system wasn't made for us. The system doesn't always, and unfortunately frequently, doesn't support us. More examples include Dr. Susan Moore, who died of COVID due to racial bias, despite being a physician, right? So she had education, she had class, and right, racial bias still killed her. Serena Williams, right? Huge world-renowned tennis player, almost died due to not being believed that she had shortness of breath after having an emergency C-section due to blood clots, which she has a history of. And so even if we went based on data, right? Black women in the US are nearly 3 times the risk of dying from pregnancy-related complications than white women, according to the CDC. So data supported her, her personal medical history supported her, and her own knowledge and wisdom of her body supported the fact that I am having something going on, and her medical team still did not believe her. And it is only because of her determinedness. She's like, I am not going out like this. You are going to do the test that's needed to take care of me, is the reason why she is still here. Historically, women of color and elderly are frequently not heard or believed when engaging with the medical system. Regardless of mental status, elders are automatically assumed to have cognitive decline and thus not completely a valid source of information on their own well-being and their own needs and body. The LGBTQIA+ community also reports delay in care due to fear of discrimination. And again, this is because collectively they know that this has been our experience. And 1 in 5 transgender patients have been turned away by their healthcare provider. So this is a huge thing, navigating this mistrust. And as Shannon pointed out, and as I hopefully just demonstrated, there's valid concern for this. So we do have to name this big pink elephant that's in the room, even if it makes us uncomfortable. And a really easy way of doing that is asking somebody, because I get not everybody's like, I can't go into all of that, right? That I'm not comfortable enough, or I don't have the training to go into that whole conversation. We can simply ask people, what has been your experience when receiving care? And what are the main concerns when it comes to the care you are receiving when you're seeking care? And by asking that, it ties back into laying that foundation of psychological safety for patients. So, all right, next slide. So when it comes to working in an organization, or even going to your own doctor, what does trust or street cred mean to you? And while y'all are answering, I'll even share, like, me as a nurse, right? And again, I've been in this field I've been a nurse for 19 years. I've been in medicine for 22. Even as a provider myself, or care team member myself, I have medical mistrust. I have significant medical mistrust, and I give side eye to my provider until we have this conversation. I've had, and I want to point out that I've had, as an adult in the medical system, receiving care as a patient, I've had 2 women of color providers, and the rest have all been white or Jewish. And my first woman of color provider violated my trust when I told her that I was starting to have suicidal ideation after starting a new birth control. And so not only did I have ideation, I had a means to follow out, because I lived in the Bay Area, which is the San Francisco, Oakland area. And my suicide ideation focused on jumping off the Golden Gate Bridge. I lived And her office literally was 15 minutes from the bridge, right? So I had the means and the access. And her response to me was to give it another month. Luckily, as a nurse, because I was a nurse at the time, I knew this was not a valid answer. And so I went to my therapist and let her know, and found another woman of color physician who not only, right, definitely was like, stop this medication, listed it as an allergy for me, but also, again, engaged with me and made sure that she listened and paid attention to anything that I brought to her. And I share this story to say that regardless of any positive affinity, right, going back to that whole bias thing that we may have, if we don't practice our actions that we've talked about, then we are either reinforcing trauma or reinforcing and causing trauma, or being a disruptor of trauma. Next slide. And thank you for everyone who answered. Because again, trust and street cred means so much to the patient populations that we serve. The next thing that we need to help build a culture of supporting SDOH need is an equity mindset. So health equity is not cookie cutter. It definitely needs to be developed in partnership with those who are experiencing the inequities. And I say that to say that what we do in Oakland, right, California, is not going to be the same that we do in Atlanta, Georgia, and it's not going to be the same that we do in Casper, Wyoming, or Montana, or Idaho, right? And that's why it's not cookie cutter. We really have to figure out, because what the different needs of each of those patient populations who are experiencing inequities, right? Because inequities are not just race, it's class, ability, rural versus urban, right? Language, all of that are different based on the area, geographic area that you're in. And so because we are all driven by a narrative, whether it's personal, familial, cultural, or societal, these narratives influence how we show up, how and who we engage with, what policies and practices we support and enforce, and who we enforce them for, as I mentioned in my previous example. And so without doing some authentic self-reflection, this means, again, looking at the narratives that we hold, which sometimes can bring up some discomfort, shame, guilt, or anger. If we don't do that, then we are guaranteed to engage in practices that are going to result in inequities for marginalized populations, even if unintentional.
Hi, I just wanted to bring up some of the questions that have come in related to affinity bias real quick, since we're sort of before we move on to the next topic. So we had someone just make a comment that I'm not sure I agree that is an affinity bias to request an English-speaking provider if one's provider has an accent. Healthcare is an area where you need to be able to clearly understand what the provider is saying, and I would ask for an interpreter if I had a patient who was ESL. And if I, as a native English speaker, have trouble understanding a doctor with a heavy accent, I have to put my health first and ask for someone I can clearly converse with and understand. And so I'm not sure if you wanted to comment, but I definitely think that there's a valid point brought up, and I'll let you go ahead and respond if you'd like.
Yes. The provider that I'm thinking in, the provider that I based this example off of didn't have a heavy accent. And there were some other things that were also going on in that situation. So, but yes, I'm like, and another way to say that is, right, is, hey, because as a result of your accent, I'm having trouble, right, understanding you. Because saying I want an English speaking provider, that provider very clearly speaks English, right? And I can acknowledge that you have a heavy accent and be like, hey, because as a result of your accent, I'm having trouble understanding you. And it can go the same way with someone who has a heavy accent who is a patient. Like, those patients also get discriminated against. And again, we can't say that I want an English speaking patient. They speak English, right? Like, again, they just have an heavy accent. What do we need to put in place so that, right, the patient's needs are met?
Great.
Is what I would go.
I just wanted to also acknowledge we have 2 other comments on the related topic, sharing exactly what you just stated. And so I want everybody to take a look at those comments and the questions if you'd like. And then simply just to ask one more question before we get to the end in case we lose folks. This is more related to the beginning of the session, but for FQHCs who have integrated dental and medical health, but running on 2 different EMRs, how are they documenting and billing? And this is a question I'd like to sort of refer back to the attendees to feel free to engage in the chat and share your experiences. I myself come from an FQHC prior, and we had our dental and health EMRs working together. So I'll open it up to the group to share their responses if they'd like. And then Kavonia, of course, you can feel free to chime in if you'd like.
I will say, yeah, the FQHC I worked at, ours was integrated as well, which is helpful. And that may be another equity gap that the organization needs to address, right? Because whoever's doing our dental, whoever patients we're serving for dental likely have a primary care need. Like how do we do that interdisciplinary cross-team collaboration? How do we do that warm handoff? And then just another thought came up behind the previous question about that someone with a thick accent. I also think the difference between the two is what's the intent behind it, right? If you truly can't understand me, then I can respect that. Versus if you like, right, if it's a true affinity bias and it's just like, I'm just not comfortable with someone who's not, right? Native, right, to the land that I'm on.
Thank you.
I want to touch on so I want to get to the 70-30 rule. We have 90 minutes, right?
Yes, we've got another 37 minutes to go.
Okay, all right. Just want to make sure, like, because you're like, some people might drop off. I'm like, hold on, did I like miscalculate this? But the right side, the 70-30 rule, in this graph, I want you to see that the 70-30 rule shows that personal behaviors only contribute to 30% of a person's health and well-being. And that, and even that can decrease based on what you have access to. So let's say I want to eat healthy, like I am all about my health. And I want to eat healthy because my doctor told me that that's going to be more helpful for to manage the pre-diabetes that I have, right? But if I live in a food desert, the likelihood, and a food desert is a place where I can't easily get fresh fruits and vegetables, right? The likelihood of me being able to have consistent access to healthy food is going to be yet one more challenge that I need to overcome, not to mention the price of healthy foods today, right? So even though I have control over 30%, some of those other percentages, right, the environmental, the social economic factors may limit how much of an impact I can have with my 30%. I also want you to see that healthcare only accounts for 20%. So that what we do in the clinic is only 20% has a 20% impact rather of on a patient's health and well-being. So with what we do in the clinic and theoretically what the patient has control over, that's still only 50% of the pie, right? And so there's a whole nother 50% that can also have negative outcomes and negatively influence a person's health and well-being, regardless of what their desire is. Okay. Any questions? Because I know there was a question on that. And I want to point out that the 50% is informed by political, social, and economic factors that are often, particularly for FQHCs, it's usually outside of our patient population's control. So it's not always something that we can definitely fix, and definitely not something that we can always easily fix. Okay, next slide. Just want to briefly share these two definitions. These are my two favorite definitions of health equity because they clearly show and name how health equity isn't an us versus them game. And nor can health equity be achieved via a single task. I want to again point out that we're all at risk of experiencing inequities. And the more categories we find ourselves fitting into, we are at greater risk of experiencing inequities. And if you look, a lot of these inequities are connected to the very SDOHs that we're trying to address. So just again, want to put that out there. Next slide. And so I am a firm believer that staff can't offer patients what they themselves are not receiving. So again, it's super important that we look at our internal organizational policies and practices to ensure that we are setting our staff up for success by providing them with the support and resources that they need to care for the very communities that we say we are committed to serving. And in the slide deck, you're going to get a link to HRSA's HC Workforce Wellbeing Initiative, where it has some content and ideas for, again, how we can better set up our organizations to support our staff. Next slide. All right, next slide. So thinking about how we continuously train our workforce to address the SDOH needs are critical. As we've already noted, so many staff touch the various social determinants of health. And so some areas where you can train your staff, again, to help them be better resourced around improving service to HDO needs include cultural humility, trauma-informed care, or trauma-responsive care. As my colleague Ebony always points out, she's like, trauma-informed care is just understanding. Trauma-responsive is action. There's also cultural safety and medical mistrust, pain management, substance use disorder. So training on pain management and what that looks like, and not just the prescription part of it for pain management and SUD, but also, again, the SDOH and the psychosocial pieces that we, the rest of the team who don't prescribe, myself included, right, can also have positive impact on, as well as that health equity mindset that we talked about. All right, next slide. So cultural humility, for those who are not familiar with it, is a practice of self-reflection on how one's own background and background of others impact teaching, learning, research, and creative activity, engagement, and leadership. I like to say that cultural humility in action is seeing our shared humanity while acknowledging our differences and not requiring the person in front of you to fit your narrative. It involves an ongoing practice of self-exploration and self-critique, combined with a willingness to learn from others. It means entering a relationship with other people with the intention of honoring their beliefs, customs, and values. It means acknowledging differences and accepting that the person for as they are and who they are. Key components of cultural humility is openness, self-reflection, awareness, lifelong learning, institutional accountability, empathy and compassion, to be other-oriented. So again, to see that person in front of you, and acknowledging power imbalances and taking steps to correct these imbalances. Next slide. Cultural humility is a powerful tool in achieving health equity by promoting inclusion, addressing that bias that we talked about, and reducing the disparities. Cultural humility also can speak to and addressing that medical mistrust that, again, is innate within many of the communities that we serve. True partnerships in health require deep respect and understanding that our patients are coming to us with a variety of lived experiences, and many of which are not readily understood. But with a strong cultural humility from providers and healthcare staff, the odds of those patients engaging as part of their own healthcare team increases, and we are better equipped to offer that comprehensive whole person care that we talk about. And as we engage in cultural humility and cultural safety training with our staff, it's really important that we think outside the box and consider the variety of different identities and intersectionalities that exist. So as I mentioned before, this is the LGBTQIA population, disabled, the reentry population, and people from different ethnicities and language. Next slide. And when we share this slide deck, all of those hyperlinks will, all the hyperlinks that are listed will take you to where you need to go so that you can learn more about those particular trainings. Trauma-informed care, or again, as my colleague Ebony says, trauma-responsive care, shifts the focus of what's wrong with you, which again is what historically has been the case, to what has happened to you. A trauma-responsive approach acknowledges that healthcare organizations and care teams need to have a complete picture of a patient's life situation, both past and present, in order to be effective in providing healthcare services that are healing-oriented. And again, healing-oriented for that person. We can't define what that healing looks like. Adopting trauma-responsive practices can potentially improve patient engagement, treatment adherence, and health outcomes, as well as provider and staff wellness. Because then you won't feel like you're constantly fighting against somebody, right? When we're being trauma responsive, we are working with that person. Same thing with working from a place of cultural humility. Okay, next slide. And so these are some links to trauma-informed care training sessions. In this section, we really wanted you to have the tools. Even if your organization isn't providing them for you, we wanted to give you some tools that you could do independently. I am a huge fan of trauma-informed supervision because, again, going back to what I said, staff can't offer to patients if they are not receiving it themselves. And that's what trauma-informed supervision is about. Like, how do we train our supervisors and our leaders to engage with staff from a place of being trauma-informed and seeing our full humanity, right? When we engage and show up at work, so that we then, right, have the capacity, compassion, the capability to also do the very same for the patients that we provide service to. Okay, next slide. So as I've mentioned and shared via my own story earlier, medical systems have a long history of deeply mistreating Black people, Indigenous people, people with physical and intellectual disabilities, immigrants, poor people, and many other. It's important to grapple with and understand this history and recognize that the continued mistreatment of these groups are still experienced on a regular basis. And while we don't have time to go into all of it, because there's a whole training on that, we want you to know that, like, it definitely does exist, and there are trainings that are available to help you start having these conversations. I want to point out that, like, in all of these training topics that we are sharing with you, and actually all of the content that we're sharing and imparting today, this is a journey. This is not a one and done thing. This is a journey that we walk on and that we grow through, and it will take time to shift and change. So I don't want to get anyone to get overwhelmed or caught up in that shame, blame, or guilt spiral that can sometimes happen. So when it comes to medical mistrust and cultural safety, as we work to address the challenges presented by these things, there's a wide variety of tools and things that we can use to address medical mistrust and secure that psychological safety. We need to improve our communication, increase our transparency, make sure that we're creating welcoming environments, attending to access barriers when we engage in them, and demonstrate to patients how we provide cares in ways to end this legacy of harm and cultivate a medical system of healing and well-being with equity at its core. Next slide. And so again, so my organization, National Healthcare for the Homeless, actually has a learning collaborative that is starting in January. That link is here. The STAR Center has a great tool on building inclusive organizations, and the Commonwealth Fund has a tool on medical mistrust among Black Americans. And I would also, again, just point out that It's not just race-based, it also is language, that people who have language barriers have a long history of medical mistrust. People who have different disabilities have a long medical mistrust, and as well as the LGBTQIA community also, right? Like, so medical mistrust definitely expands. Next slide. I wanted to include pain management and SUD in here because this is such a big thing that's going on right now. And right along with that whole medical mistrust, one of the things within the Black community is that it is a long held, like 170-year plus belief that Blacks don't experience pain, and our pain has been consistently diminished. And I would even say other Black and Brown people also, right, have this lived experience too. So wanted to make sure that we included this, particularly since research demonstrates a linkage between chronic pain and a number of social determinants, including mental and physical stress at work, social economic status, rural status, occupation, neighborhood, education. And so patients with a lower education are 2.8 times more likely to develop chronic knee pain after knee surgery. That's what that is, compared to those with higher education levels. Like, there is a link between the pain and SDOH. So definitely wanted to highlight here. And ensuring that we're including training on pain management and its connection to SDOH for all staff can mean the difference between chronic pain and potential opioid misuse, as well as quality of care that addresses the pain early and effective before it becomes a chronic issue. Next slide. List of resources. So similarly, substance use disorder and SDOH are also linked together. When we address SDOH, we can improve health outcomes and reduce health disparities related to substance use disorder. Training our staff on increasing services around employment, housing, education, and more can improve lives of people who have and are navigating substance use disorder, because just because you are living with substance use disorder does not mean that you cannot be functional. I know a whole bunch of functional people who engage in substance use disorder. And I also want to point out that, like, oftentimes in my experience, substance use disorder has been a way of coping with something else connected to our SDOH needs. So if we can address some SDOH stuff, right, then maybe people would not need to cope, right, in this way. And I also want to point out that we all cope in some way, right? Whether it's eating our emotions, whether it's binge watching, whether it's binge shopping, right, gambling, right, there's smoking, there's all sorts of things. And so really important not to stigmatize this patient population. Additionally, as we mentioned, creating more trauma-informed or trauma-responsive organization can also eliminate and mitigate some bias and stigma around SUDs, leading to improved patient care and outcomes. Next. And so we talked about a health equity mindset, but we wanted to give you some resources on how to do health equity. It's also, and it's one of my favorite topics. It's one of my favorite trainings. So provided you with some resources here. Next slide. Okay, I just dumped a whole bunch of trainings out at y'all. And my question to you is, of the subjects that we, quickly went over, does your organization train on any of these? Shannon, is there anything in the chat that I need to?
Yeah, there's actually a great comment and question. Somebody asked where the myth came from that Black people don't feel pain the same way. And they're wondering if you could answer some of those.
Oh, I can. So Dr. Sims, who is honored as the father of gynecology, learned his skills at the expense of Black female slaves. And his logic was that because Blacks don't experience pain, they didn't need to provide anesthesia to these female slaves. And this was a common thought. Blacks were deemed to be hardier, more resistant, hence naturally inclined to the life of a slave. It's because we have been degraded and seen as inhumane or more animalistic, particularly during that time period of Dr. Sims. And there's also the myth that our skin is thicker and then thus more durable. And so we don't experience the same pain levels as white people. But yeah, no, so between all of that plus Dr. Sims' research, that's where that legacy come from. And if you want to learn more, there's a book called Medical Bondage that goes into deep detail about how the profession of obstetrics and gynecology was done at the expense of the Black female body. Okay, I heard something for folks by phone. What's up?
Yeah, so some people have logged in by the phone if you want to read some of the results from the Mentimeter so they can engage.
Yes. I know it's giving people time to chat, respond. Okay, so we seem to have a really good response from like cultural humility, trauma-informed care, and substance use disorder training. Health equity mindset, I'm actually going to happy dance on that one. Cultural safety are all high responses. Medical mistrust and pain management are our two low ones. So those are some subjects that organizations aren't currently training on. And as you can see, as again, hopefully between all the stories that I've shared, medical mistrust is actually something we should be doing just as much as cultural humility and trauma-informed care. I really feel like they're all intertwined, because you need to understand what I bring with me, that legacy, and acknowledge what we've done, right? That legacy of harm that we've done. Yes, Medical Apartheid is also a good book. I always tell people to have something soothing with them when they do, if they read Medical Apartheid, because it's a rough read. It really makes you question engaging in healthcare. And then there was a question on cultural safety. Cultural safety, and there's a link. There's a fabulous group that is out of Canada that is starting cultural safety training, and it's an online training, totally free, that you can sign up for, and it's going to be, again, included in the links in the slide deck. Cultural sensitivity is kind of like, I understand that you have cultural I'm sensitive that you think differently than I do, or you experience life differently than I do, or you have different cultural practices and beliefs than I do. Cultural safety is more action oriented. It's kind of like the difference between trauma-informed care just being about understanding knowledge versus, thank you, trauma responsive care being about action. Cultural safety is about action. How do I make this safe? How do I turn this into a safe space for you? Because I know of the cultural harm that you have experienced, right? This is not just because we have a cultural difference. Because of the cultural harm I know that you've experienced, how can we change this system? How can we change it so that we are not replicating those harms? Okay, next slide, because I'm about to blow through some things. I got my 15-minute warning. Okay, additional tools, because I am the director of Justice, Equity, Diversity, and Inclusion, so I got to include all my stuff. Types of language and accessibility. We wanted to make sure you had a couple of slides on that. Next. And so here literally is just some links to give you language tools. on health literacy, on a language access kit, which Shannon, that's from your organization. You want to say anything about that? Because it looked super awesome.
That's actually from our partners at the National Center for Farm Worker Health. They have really great information on language access tools. I really think you would benefit from checking it out. But I will save some more time for you to go ahead and go through the other tools.
And then the Guide to Person-Centered Communication by NAC, also super fabulous. The Population Health Team led by Nalani, super, super awesome. Highly recommend. Again, you'll have access to all of these links. Next slide. And then I also want us to always be acknowledging around accessibility, whether it's visual, intellectual, right? Because we have people who are neurodivergent and just process information differently than us. Super important, so wanted to include that in there. Next. Again, policies and practices, I feel like you cannot create a supportive environment that's going to meet SDOH needs without looking at our policies and practices. So next slide. So again, we need to cultivate our organizational cultures so that we are building successful SDOH programs. So we need to make sure we're building inclusive environments for our patients and our staff, which means that we need to be engaging and thoughtful and equity-minded, policy making, and procedure writing. Next slide. And so again, ACU and the Star Center have some great resources around building that culture and cultivating that culture of inclusiveness. Next slide. Secondary burnout, secondary trauma are real, significantly real. And again, in order to help our staff have the capacity, have the resources, and feel supported in the way that they need, we need to make sure that we are supporting our staff. Because if our staff is burnt out, then they can't provide care to the patients and communities that we are looking to serve. And the communities that we serve come with complex issues. Heck, some of the people we employ, right? Like myself included, like we've got complex backgrounds, and engaging with our patients and communities can sometimes trigger stuff within ourselves. And so again, we need that extra internal support from our organization. We're going to do our own work, and having that cushion within our organization also like just cannot be expanded upon enough. Next slide. Was just doing a quick question, how people are engaging. And so the question for people who are on the phone, the question is, how often do you engage in organizational training on SDOH subjects? And it looks like, thankfully, we've got more answers of frequently and sometimes rather than rarely, or my organization doesn't offer this, which again, just breaks my heart. Okay, I'm gonna slide us through the next slide so that we can make it through the last two.
We can do it.
Next slide.
Awesome. So thinking about tools for identifying emerging needs in our organizations. We wouldn't be the SDOH Academy if we didn't talk about tracking why we need to monitor needs and use the resources at hand to assess our patient needs. So why monitor? We want to know what's happening. Our populations are continuously changing. I'm sure your neighborhood, city, health center has seen a change in their population from 5-10 years ago. We're seeing people moving all around, and we definitely need to be sure to know who is here and what their needs are, identify gaps in care so that we can address them. So there are a lot of SDOH tools available to measure the social determinants of health. And I'm just going to give 3 examples, but of course there are a plethora to use. So we have one that is the Prepare tool. It was actually developed by our fellow NTAPs at APSHO and NAC. So you probably have heard of this before. This is a really comprehensive tool. It has between 13 and 36 questions and goes across all of the 5 domains of SDOH that we had addressed at the beginning of today's session. It can be used by a lot of FQHCs, but it's not only for health centers. It could be used by anybody. So it's definitely something to check out. WellRx is another example of a shorter, more simplified tool. It has 11 questions, only covers 4 domains, but it might be more simply integrated into somebody's organization. And of course, there are other tools like the ACH HRSN, Accountable Health Communities Health-Related Social Needs Screening Tool, which was developed by CMS. And this is really a tool that's meant to sort of track what it is to assess needs and fill in those needs for accountable care. Let me make sure I'm not missing this description. Accountable care communities, exactly. Yeah. So we have 3 examples here. There are 21 different tools that you can find. The National Center for Farm Worker Health, I actually am not working with them, but I work very closely with them through the Farm Worker Health Network. They just have such great resources that are relevant to SDOH. So go ahead and check out their resource hub for SDOH screening tools. You can find a lot of information there. And you can also find information on Kaiser Permanente's website. I didn't get it in the slide here, but I will post it in the chat. And they have a list of 21 different SDOH screening tools, pros and cons of each, that you can go ahead and check out and see what might be good to use at your organization or with your program. Next slide.
I love that they have the pros and cons.
Yeah.
So I don't have to trial and error them myself. And again, trying to be mindful, I want to just point out, like, as we are encouraging you to collect data, I want to point out that data in the name of quality improvement, research, public interest, or just simply, right, trying to meet SDOH needs has its own role in medicine's legacy of harm and medical mistrust. And so it's really important that we need to be deliberate in our actions to avoid weaponizing any data that we collect from patients. Data itself isn't bad, good or bad. It's really how we use that data where that impact can collide. And so be aware, again, laying that psychological safety foundation, acknowledging that medical mistrust, because the communities that we serve have an extensive history of medical violence and oppression, our attempt at collecting some basic data to address their SDOH needs can still feel like a violation of trust. It can still feel unsafe to them. And we, again, if we really want to walk our talk and help them in the ways that we say, we have to be aware of that. Okay, next. So this is just a quick down and dirty bullet points on data collection efforts with an equity lens. This is how you can do it in a way that is not extractful. It's a way that you can help you develop and demonstrate how your use of collecting data is going to be different. I will also say that as you collect data, whether for SDOH needs or something else, anyone who's collecting it really needs to be well-versed in why we're collecting, what we're going to use it for, and how it's going to improve or impact the community being served or the very patient who is in front of you. Okay. And then when it comes to addressing individual SDOH needs, it's important that we remember that 70-30 rule. If patients are already overwhelmed or burdened down by the 70% of what contributes to their well-being, which includes how we provide care or deliver our recommendations, or how, or if we've laid down that foundation or not, their capacity to take action may not be there. It's likely going to be compromised. And outreach nursing taught me, if it didn't teach me nothing else, and I've loved my years as an outreach nurse, that if I don't address whatever the primary concern of my patient is, then the likelihood of anything that I recommend to them doesn't mean squat, right? And it makes sense, because why should they listen to me when I ain't listening to them? right? That's literally the clear message that I'm sending when I don't also address their needs and prioritize what I think they need instead. So again, being aware of that 70-30 rule, paying attention to what it is that they need to prioritize, and then adding what you need. And then I want to also, the patient activation measure. I really like this. There's a community health center called HealthLink that's using this in Indiana. It's 10 to 13 questionnaire that assess a patient's readiness and capacity for doing our healthcare recommendations. And it's really great tool for community health workers, which is why I included it. If patients rank 1 or 2, then community health workers know to dedicate more time and spend more time with them to help them navigate the various barriers and roadblocks that are contributing to the health challenges that they're experiencing. If they rank a 3 or a 4, the community health workers a little bit more hands-off. They still get the same resources. They still get the same resources, but because they're deemed at a higher level of readiness and engagement, they're given it to them and allowed to do on their own. But at it's either a 60 or 90-day checkpoint, the community health worker will check back in with that patient who ranked a 3 or a 4 to see if they were able to get their needs met. And if they were, great, fabulous, we go on to the next thing. If they were not, then we move them back and be like, hey, how can we help you? What got in the way? What additional supports do you need? And so this is a great tool to use because people's capacity changes based on everything else that is going on in their life. I even know for myself, my doctor gave me a neurology referral September 6th. I didn't even think about making a phone call until November 28th, right? So if I was that patient, I would have, they would have thought, oh, she's a 3 or a 4. It's fine. She can do this. And then if they did that 60-day checkpoint, I'm like, I just made it under the buzzer being like, oh, yeah, no, life got in the way. So that makes such a difference. Okay, next slide. Community partnerships, we cannot do this alone. Cannot do this alone. SDOH needs were not created in a vacuum, nor should we think that we can solve them in a vacuum. So reaching out and figuring out who we need to develop partnerships with is just actually, quite frankly, in our best interest. Because to truly address the SDOH needs, rather than applying a Band-Aid to them, we need to partner with other communities embedded within the organization. And develop and maintain strong partnerships with these community-based organizations and other community partners. So I'm gonna leave it at that. Go ahead to the NIN because we need to talk about our next session.
Thank you so much. You did a great job, everybody. Thank you for your comments and engaging. I wanted to just mention that we've got session 3 coming up February 1st. The link is in the chat box to register. Please take a moment and go ahead and register to get some really great information. And then we will also share with you the link to complete the evaluation for today's session. So if you want to go back to the next slide. We don't have any time to answer questions. We have 1 minute. There's one question left for those who want to stay and hear the end of it. It was from Chris here in the Q&A. Kavonia, do you have any tips how to get more organizations to practice what they preach? I see so many programs that advocate to others about how to be trauma informed, inclusive, empowering, etc., but often do not want to foster this within their own organizations, staff, and policy.
There is not a quick answer to that. Chris is going to have to email me. And I am happy to put my email in the chat because that is not a short answer.
Definitely need to build that culture within the community, within the organization, and it doesn't happen overnight. So any other questions, feel free to reach out to us. I'll put my email also in the chat. And thank you everyone for joining today's session.
Oh, and the next slide, I think that has the feedback. No, next one, that one. Please take a moment, anybody who's still here, and
we've got them in the chat a few times throughout the end of the session. So hopefully those who had to leave could log in. Thank you so much.
All right. Thank you, everyone.